Hello students, today we will discuss All India Difficult Airway Association 2016 guidelines for management of difficult unanticipated difficult tracheal intubation in adults. Today's topic is very important. It is commonly used in examination. The airway management is very vital. It is a vital skill. Inadequate airway management result in adverse outcome. Now we will see preoperative airway assessment and preparation. Preoperative assessment should be performed to identify factors leading to difficult face mask ventilation, supraglottic airway device insertion and tracheal intubation. The reduction in gastric volume and increase in pH should be done before surgery by adequate fasting and pharmacological means. Mechanical drainage using nasogastric tube should be considered. Preoperative sedation should be used with caution in patients with anticipated difficult airway. In patients with compromised airway, sedation is best avoided. Then we will see optimizing endotracheal intubation. How will you optimize? Pre-oxygenation and peri-intubation oxygenation technique. Number 1, the optimal pre-oxygenation increases non-hypoxic apnea time. It provides safety margin before desaturation occurs. Pre-oxygenation and mask ventilation to preserve oxygenation until airway is secured by giving neuromuscular blockade. Following different techniques of pre-oxygenation and peri-intubation oxygenations are done. Number 1, head-up position. Pre-oxygenation should be given using 20-degree head-up position unless contraindicated. This position more comfortable to patient to take full breaths. In flat position, posterior portion of lungs are more prone for atelectasis and collapse. It reduces oxygen reserve, so it shortens safe apnea time. Number 2, mask fit. Ensure proper face mask fit. The pre-oxygenation should be performed for 3 minutes with tidal volume breathing. It can be prolonged for 5 minutes if face mask leak is present. Pre-oxygenation with 8 vital capacity breath for 60 seconds is also alternative method that is more effective. The pre-oxygenation following forced exhalation followed by tidal breathing is also effective. Target end tidal oxygen should be more than 90%. And end tidal nitrogen should be less than 4%. Second, oxygen flow rate. Third, oxygen flow rate. Deliver at least 10 liter per minute with an open circuit. It is mandatory during pre-oxygenation. When closed circuit is used, pre-oxygenation should be done with pre-filled oxygen using minimum oxygen flow rate of 10 liter per minute. Fourth, continuous positive airway pressure. Application of continuous positive airway pressure of 5 to 10 cm of water during free oxygenation is recommended if not contraindicated. Fifth, pressure support ventilation. Pressure support ventilation of 5 to 15 cm of water should be applied if possible. Non-invasive ventilation also improves effectiveness of pre-oxygenation. Sixth, apneic oxygenation using nasal cannula. Insufflation of continuous oxygen at 10 to 15 liter into pharynx through nasal cannula can extend duration of safe apnea time during muscle relaxants are used. Oxygen delivery through nasal cannula is 15 liter per minute. Then Induction agents and neuromuscular blockade used. First, propofol is used to suppress laryngeal reflexes. It provides better intubating condition. Ensure adequate depth of anesthesia during repeated attempts at intubation to prevent awareness. Neuromuscular blockade can be given with succinyl or we can use rocurinum. The dose of rocurinum is more than 1.2 mg per kg. Next, proper position during or before intubation. There should be flexion of neck and extension at atlanto-occipital joint. That is a classical sniffing position. That position can be given by keeping a pillow of 10 cm thickness under the head. Next, we will see laryngoscopy and intubation. Nasal oxygenation using oxygen flow at 15 liter per minute is given to maintain oxygenation during apnea. Repeated attempts of laryngoscopy should be minimum. It can increase risk of cannot ventilate situation because of airway trauma. We can use video laryngoscopy or conventional laryngoscopy. Then optimal external laryngeal manipulations are applied. We can use gum elastic bougie can be used. Next, we will see the confirmation of endotracheal intubation. Number 1, visual confirmation of endotracheal tube between two cords, vocal cords. Second, bilateral chest expansion. Third, 5-point auscultation. Fourth, capnography. Continuous sine wave capnogram. Presence of 6 consistent capnography traces without decline in CO2 levels. It will confirm the endotracheal tube intubation. Next, role of supraglottic airway devices as a rescue device during difficult airway. When endotracheal tube fails, placement of supraglottic airway device helps in maintaining oxygenation. We should use second generation supraglottic airway devices with higher ceiling pressure, and tube for gastric drainage should be preferred. At least 2 attempts of supraglottic airway device insertion can be taken. Next, we will see the complete ventilation failure, where tracheal intubation, face mask, supraglottic airway devices failed. Then we can label it as cannot intubate, cannot ventilate situation. Now we should proceed for emergency cricothyrotomy when complete ventilation failure occurs. During these events, nasal insufflation should continue. Now, H, calling for help. We should call for help as early as possible when first difficulty in airway management is encountered. Then we will now discuss emergency cricothyrotomy. It is necessary when there is complete ventilatory failure, when we are not able to intubate, ventilate with face mask and unable to put supraglottic airway device. Now we should see the anatomical landmarks. The boundaries of cricothyroid membrane are following. It is formed by thyroid cartilage superiorly, cricoid cartilage inferiorly, thyroid muscles laterally. The membrane, that is cricothyroid membrane, is approximately 10 mm in height. It is 22 mm in width. It is made up of dense fibroelastic tissue. Cricothyroid membrane is superficial. It can be easily felt. It is less mobile structure. It is held steadily in place. It is a vascular structure. It is placed away from thyroid gland, anterior jugular vein and laryngeal nerves. It is easier and faster to perform. That is, cricothyrotomy is easier, faster to perform than tracheostomy, and chances of bleeding are less. Now we will see the patient's position. Patient's Patient is positioned supine with neck extended by using a pillow under the shoulders or dropping head over the operating table. Use antiseptic technique. Use universal precautions. Mark cricothyroid membrane before induction of anesthesia in patient with anticipated difficult airway. Now we will see the techniques. There are two techniques, surgical cricothyrotomy and cannula cricothyrotomy. The surgical cricothyrotomy, that means insertion through cricothyroid membrane and insertion of tracheostomy tube. Scalpel with number 10 blade is required. Also gum elastic bougie with angle tip and cuff endotracheal tube of size 6 mm are required. During the procedure, nasal oxygen at rate of 15 liter per minute should be given. Now second, we will see the cannula cricothyrotomy. A. Narrow bore cannula technique. A 14 to 16 gauge cannula with its needle attached to saline filled 10 ml syringe is inserted through cricothyroid membrane in caudal direction at angle of 30 to 50 degrees. Correct placement is confirmed by aspirating air. Push catheter over needle into trachea and remove the needle. Then correct placement is reconfirmed by using saline filled syringe. Start pressure regulated jet ventilation. It requires jet ventilation using high pressure ventilation source, and it is associated with barotrauma. That means pneumothorax, pneumomediastinum can occur. This technique requires patient upper airway for exhalation. Now we will see wide bore cannula technique. It includes commercially available kits. Wide bore cannula allows exhalation. Some sets have cuff and thus protects the airway. It can be used with standard ventilator and breathing circuit. It is less invasive than surgical cricothyrotomy. It avoids need for jet ventilation. Various devices, cylinder technique or wide bore cannula over trocar technique. Trocar devices carry risk of perforation to trachea due to force required to insert, leading to distortion of trachea. Cricothyrotomy should be converted to tracheostomy at earliest to avoid tracheal stenosis. Thank you.